Welcome to AFibulous Life, Unlimited Conversation, the podcast where we explore what it really means to live, adapt, and thrive with atrial fibrillation. Hosted by Jim Kaveney, this is a space for real stories, expert insights, and honest conversations about heart health, resilience, and life beyond diagnosis, because AFib doesn't define you. And with the right support, your life can still be unlimited.
So welcome back, and tonight we're going to chat about being on both sides of the bed when the doctor becomes the patient. So particularly the core question we want to emphasize tonight is what happens when the people trained to care for others have to learn how to receive care themselves, and what does it cost, and what does it give the person standing beside them? Now, in addition to that question, we're also going to state really why does this matter? And this is our first episode featuring both a patient and a caregiver. And the first time both of these guests are also healthcare professionals themselves. So this is going to let us explore AFib from three angles at once. So the clinician's mind, the patient's body, and the caregiver's daily reality, which is both psychological and physical. So Scott Helsley is our guest tonight. Dr. Scott Helsley has spent his career on the other side of the table, the one holding the mask, watching the monitor, and telling patients you're going to be fine throughout all of this. But then one day, Scott himself became the patient and was on the table. And the person watching the monitor beside him wasn't a colleague, but it was his wife, Jessica, a nurse herself. Except now she wasn't clocking out at the end of her shift. She was going to go home with this. And so this is why it's so awesome we're going to talk today, because we're going to dive into something we've never done before. So like I said, we're bringing this patient and this caregiver together. And it's oftentimes the caregiver that kind of gets pushed aside, right? Because we're so worried about the patient. But what about the caregiver's health? What about the caregiver's psychological framework as well? Because they can't take care of somebody if they themselves are not strong. So we're going to dive into that a little bit tonight too. So I am so excited to welcome Dr. Scott Helsley and Jessica Helsley on the AFibulous Life Unlimited Conversation. So guys, welcome to the show tonight.
Thank you. Hi, thank you so much for having us.
So happy to have you here. And obviously a caveat too is we've known each other for many, many years. So Jess, you and I have known each other, gosh, I mean, I'm going to date myself because I'm 52. So we've probably known each other for close to 30 some, maybe even longer, maybe even 40 years, which is crazy.
About 40, yep. Mm-hmm.
Yeah, which is crazy. So that just means that our brothers and our sisters and everything else are quite a bit older than us, if that's possible. So let's take a few minutes, guys. Jess, let's talk with you. Ladies are always first. Tell us a little bit about yourself, your role, your history. What do you do for a living? Diving into your healthcare experience.
Well, my name is Jessica, and I have been a nurse since 2006. I've been a orthopedic trauma nurse for 14 years now, and yes, Scott and I have been married since 2015. And what else?
Awesome.
Just what else do you want to know?
No, I think that's golden. That is golden. And the purveyor of health for Scott. Obviously, you're keeping him in line. So that's great. So, Dr. Scott, how about your background?
Well, I obviously a physician, anesthesiologist. I also have a PhD in pharmacology. I've been practicing medicine since I finished residency in 2002. So it's been about just under 25 years of that, practicing anesthesiology, private practice, community-based hospital.
Yeah, that's awesome. And your backgrounds are so robust, so full of intelligence. And really, I guess when you think about what you've gone through on your own medical training, both of you really, when things start to go awry, like what's the first thing that you start to think about from your shifts? Like Scott, let's just shift to you obviously directly, right? So when things started not feeling great, and before we get into this too, I want you guys to define who you are outside of work too, because I think that's important. Okay. Yeah, so because you guys are heavily involved in the physical fitness community too as well, correct?
Yeah, so I'm also a nutrition coach, and I've been into fitness for many years. Strength training, I currently do strength training right now. Like I said, I'm a nutrition coach. I help a lot of women in midlife Try to guide them with proper nutrition, strength training, perimenopause, things like that.
Wow.
So,
Yeah, that's awesome. That's awesome. And Scott, you're heavily involved, where you were heavily involved in like CrossFit and things like that too, correct?
Not particularly CrossFit. That's more Jess's angle. I was more into just I did a lot of rowing, not at the collegiate level or anything like
Yeah.
that, just recreationally and a lot of weightlifting. Running races, things like that. Just always trying to be active and exercise.
mhm.
Yeah.
You know,
Well,
as a part
I
of
Kettlebell
love
training,
kettlebell training. Yeah, that was a
kettlebell
big one.
training. Hmm.
Yeah, yeah. Well, I love that word rowing, right? Because that's what I did. I was a rower in
Yeah.
college, so I love that. It's always great to meet somebody that is as sadistic as I was. Getting on one of those things is not the for the faint of heart. But
No,
and
it's not.
it's probably a great segue into what we're ultimately going to talk about. But
Yeah.
so this is a great story because here you are, obviously young, vibrant, full of health, all the great things that you're doing to keep yourselves in that position. And then Scott, let's go back to that question I had earlier. Is like when you started to realize something wasn't going right with your heart and you ultimately were diagnosed with AFib. Can you explain a little bit about that experience for you and what made you kind of sit up, take pause, and say, "Hey, I need to take a look into this."
Well, it started. I would always kind of have little palpitations here and there when I'd lay down at night most of the time. That's when I would notice, little palpitations that pretty much
Yep.
everyone gets and didn't think much of them because, they're common and usually inconsequential. But then I distinctly remember when this started, we were hiking in California. It wasn't a very strenuous hike or anything like that, but I started noticing that I'd just get these little runs of it that lasted longer. And I never used to get that during that time of day or doing that sort of thing. It was always at night when I'd lay down, I'd get a couple and then it would stop. But this was a
Okay.
little more persistent and had continued a little more frequent than I had been used to before.
Sure.
At the time, I didn't have my primary care physician had retired, and so I kind of blown off getting a primary care physician. I know it sounds odd that a physician would not
Sure.
have their own physician, but I think it happened more than people would think.
Sure.
And I had finally started, once this started happening, I was like, I got to get on the ball with this. So I found a primary care physician, went in there, saw him, asked what was going on. I said, I'm having these
He's got cardio.
palpitations here and there. And my physician has been great with me about it. And he said, he recommended, said, get a cardio, see what's going on. But he goes, in the meantime, we'll get a Zeo monitor on you, get a
Sure.
3-day study, see what's up. So puts the Zeo on, and I've got like, I don't know, 60 some runs of SVT in a 3-day period. And he called me up actually when he got the results. He goes, this isn't normal. He goes, we need to
Sure.
get you in for a study.
Sure.
Might I add, Jimmy, that while we were on vacation and this was happening, he never told me anything. And so if something were to happen, I would have had
Yeah.
no idea. So this already wasn't starting well. I'm so upset. I'm like, why wouldn't you tell me that you're going through something like that? So I know, I think
Yeah.
that's, yeah.
In fairness to me, I didn't know what the significance
Right, but
of
you
it
knew it
was
was
or if
something
it was anything
different
that was
and, it
serious
would
or
have,
not.
Yeah.
anyway.
Yeah.
So, and I think that's a great point, Jess, too. And I guess I'll take it back to you, Scott, right? Obviously her red flag as a caregiver, going up big time, like, oh my gosh, you didn't tell me soon enough.
Hmm.
But I guess going back to Scott, because again, you're a physician. Do you think that your medical training held you back from taking the step? So maybe if somebody, I mean, I'm not a medical doctor, but I know for myself, like when I started going through my own issues, like I didn't tell my wife either, like right out of the gate, and I'm not medically trained. So I'm just wondering, what was that because you're so well versed and you're a physician yourself, like maybe you were just kind of brushing it off a little bit more than you should have, or anybody in general should be.
I'm not really sure. I don't know how much. I, Obviously, I can't uncouple my non-medical
Sure.
self from my medical self. But at the same time, I seem to be pretty okay at disassociating that when I have to. And I think I just handled it like kind of like any guy would, or a lot of
Sure.
guys would, and just,
Yep.
it's nothing. I mean, I'm obviously not getting short of breath with this. I'm not having any difficulty completing any daily activities here. This isn't a crisis. But in the back of my mind, I was like, this is obviously something that needs to be looked at,
Yeah.
because, I did put my medical hat back on and say, like, listen, if this was my patient experiencing something like this, I would want to know about that.
Right.
And if
Yeah.
you were experiencing
Right.
something like that, I would want you to tell me about
Right.
that.
Mm-hmm.
So,
Yeah.
I guess I should hold myself to that standard. So,
Sure.
obviously,
Sure.
you got to do the right thing eventually. It just takes me longer sometimes.
Right. And that's one thing that we obviously try to hammer home here on the show all the time too, is the care team that you have is first and foremost your caregiver, but also your doctors and everything else, and just making sure that we're openly communicating, because just a singular pitter pat, while we might dismiss that, you should probably always, we always try to say, please sit up and notice and start having a conversation. The sooner the better, because I know in my situation there probably were a few months that went by that probably shouldn't have, which led me to my more serious situation that I went through. And every patient's journey experience is obviously unique to them as well. So, but I appreciate you sharing that with us on that side. So, what was, when you were on the other side of it and you started getting your care, I guess let's define a little bit about your journey specifically. So how long were you, from being diagnosed to the point in which you started either, and did you go on to medicine right away? What was the doctor's protocol or path for you?
Well, it was a little unusual because it didn't present like typical AFib type situation. I had months of this palpitation kind of symptoms, mostly PACs, a few PVCs here and there, but it was mostly premature atrial contractions that were just little runs, couple, 3 or 4 in a row, and then it would stop.
Yep.
It wasn't until around this started. We were in California around September. By around Thanksgiving was the first time I went into AFib.
It was the day after
Yeah.
Thanksgiving.
Okay.
Yeah.
Mm-hmm.
And so, I had already seen my physician a couple of times about it. My baseline heart rate was so low, in the low 40s and high 30s, that they didn't think that any medications would be ideal for me, because they would just
Sure.
slow my heart rate down and make me feel worse.
Right. Right.
So that wasn't really an option, but we were just kind of watching this, started taking a little bit more magnesium, things to make the heart a little bit more stable. Had an echocardiogram that was entirely normal. So everything structurally was okay. They weren't worried about anything in particular, but they were just kind of like, wait and see what happens. Well,
Sure.
the other shoe eventually dropped.
Mm-hmm.
Sure. Okay. And that was, so that was right around Thanksgiving is when things really started going awry. And
Yeah.
then what about then because you ultimately received an ablation, right?
Yep.
Okay. And that was how many months post Thanksgiving?
That was
February.
February. Yeah.
Mm-hmm.
Oh,
Beginning
okay.
of
So that
February.
was relatively
3
quick.
months.
Yeah.
Relatively quick.
Yeah.
Mm-hmm.
Not too bad. And that was then 2 years ago, 3 years ago?
Would have been a year ago, past February.
Oh, it's only been, okay,
Yeah,
only
so
been a
he
year.
had gotten cardioverted first. So the day
Okay.
after Thanksgiving, when he went into AFib, and like we had talked about, he did the cardia, he was in AFib. It was a really slow rate. And I, knowing what I know about AFib, I knew it wasn't presenting typically. And so he kept minimizing, saying, I'm okay.
Sure.
And I could hear him walking around the house, like taking
Yeah.
deep breaths. And I finally looked at him and said, you need to sit down, and I'm taking your blood pressure, and we're going to the hospital. And
Yeah.
so he listened to me finally. And
Good.
but I will say that he ended up driving himself to the hospital. And I was completely upset and confused by this because I wanted to be with him. And it was almost as if, he was acting like this was a burden to me or something.
Sure.
I don't know if that's the right word, but I'll be fine. I can get myself to the hospital. I'll go get this cardioversion and I'll be home, kind of not
Sure.
a big deal type of thing. But in my mind, I was like, what do you mean you're driving yourself to the hospital?
Right.
I'm your
Right.
wife. I want to be with you. And, so, we went through a little bit right at the beginning with all of this. And, so.
Yeah, that was a mistake on my part. I think that I in a way, I is trying not to be a burden. Actually, probably deprived Jess of a very important job at that point in time, and I should have let her just take me to the hospital. I didn't want her to get stuck there waiting. I didn't know how long we were going to be there.
I mean, I'm the last person he needs to worry about, right? At that time.
And all that stuff. But it was actually, everything moved very quickly there, and then she came later.
Mm-hmm.
But I was, my argument was, I don't even know what's going on quite yet. Let's see what happens, and I'll call you and I'll let you know what's happening, and we can go from there. But I should have just shut my mouth and let her take me to the hospital.
Well, from that point forward, we had a conversation, and I'm driving from now on if happens.
No, that's great, and I appreciate the honesty and the transparency about that experience, because it's not too dissimilar from what mine was, right? I mean, my situation was I went to my cardiologist office first without Lisa, because I'm like, I've got this, and then I remember he said, well, we could do a quick little procedure, called an ablation. You're young enough. I was 38 when I was diagnosed. And he's like, yeah, we can get in there, clean it up real quick, and you go about your way. And I said, no, let's start with the medicine, first, and then it just turned out to be a much longer journey. So I think had my wife gotten involved a little bit earlier, it probably would have been a little shorter too. So I appreciate your transparency there on that. And so just kind of sticking with you, on that side, when you think about, the clinical instincts that you've had over the years of experience that you've had as an orthopedic nurse, right?
Mm-hmm.
How did that help you, in addition to obviously what we just discussed, but were there other things that made you more aware of what was happening for Scott and for yourself?
You were a cardiac nurse too.
Well, I do have, yes, I was a cardiac nurse for 7 years prior to the OR. I worked in CVICU, and so in the open heart operating room. So I had that experience.
Tuned into that.
And then I was even more so in tune and had one eye on him after that happened, because I thought, he's not going to tell me anything. I'm going to have to watch him like a hawk, And so, but then over time, we learned what his triggers were, learning about vagal AFib, because that's the type that he does have, which isn't typical. And so I kind of had to reverse what I knew about AFib, because it was so different. And I knew that we had a lot to learn together, and just moving forward. In the beginning, I was stressed. I was, sleeping with one eye open. Is he okay? But then, like I said, as time went on, we were able to manage a lot better. And then I was able to kind of calm down a little bit and just relax so.
Okay.
Mm-hmm.
No, that's great. And if you don't mind, can you explain a little bit, right? Because our audience is pretty broad. So you're a vagal AFib patient. Can you explain that a little bit, Scott, for the audience, just from your perspective? Like, how did they define that for you, as opposed to what is the standard run-of-the-mill AFib patient?
Yeah, typically, atrial fibrillation, as you know, is associated with more sympathetic drivers, too much stimulation, some people, caffeine's a big trigger for. Other people, it's not. But some people, when they get startled, when they get exerted, that'll kick them into AFib. It can also be mediated by parasympathetic nervous system, in a way that when your heart rate slows down enough, and if you've got a little bit of chatter going on in the electrical system of the heart, what happens is, normally when the heart's going at a fairly good clip, the electrical excitability of the heart goes into a refractory period.
Yep.
And so those other signals can't set up shop and create what's called a recurrent pathway. In the case of people with extremely slow heart rates, that refractory period only lasts so long, and then there's an open window for the conduction system to go awry if there's that aberrant stimulus. And so that's kind of what it seems to be happening. And you see that in a lot of people that are endurance athletes over the long haul. There's some changes in the atrium. They think maybe some stretch a little bit, and just enough to cause some instability in the conduction system and some alternate pathways where that electrical signal can travel, and then that sets up the circuit for atrial fibrillation. And so, whereas most people have sympathetic drivers for that, like fear, startling, or something like that, people with vagal AFib can be triggered by things that make the heart rate slow down. One of my biggest triggers is cold drinks.
Yep.
Or carbonated drinks.
Popsicles.
Interesting.
Yeah. A full stomach and a cold drink is a setup. And
Wow.
both times I went into AFib and stayed into it. Well, the first time I think I went into it, I was shoveling snow out in the cold.
Yep.
Okay.
And that one kind of just cut itself off. But then another time I was drinking a cold carbonated beverage. I think it was Liquid Death or something like that.
Okay. Yeah.
Appropriately
Sparkling
named.
water. Yeah.
Yeah. And
Yeah.
it kicked me in, and I stayed in it. The next day I just went and got cardioverted out of it.
So he had 2 cardio
I had
versions.
2 cardioversions
before the
my
ablation. Yep.
Yeah. But
Okay.
yeah, cold drinks all the time. Even now, after my ablation, I can get a little funky after a cold drink or a popsicle, but it doesn't last.
So you're a teetotaler now, drinking just warm beverages from now on. Oh wow, that's fascinating. 'Cause, you know, it's and I've heard stories of patients that are like that. And I never met one, so now I've met one, which is pretty. That's pretty incredible, really.
You know,
Wow,
one of the biggest procedures that you know, as an anesthesiologist, that we do outside of the OR, we do a lot of cardioversions, where you know, which we do under sedation. But this has given me a new insight into it, and I'm always talking to patients and kind of asking them about how their experience with this has gone. And everybody, it's a very interesting condition because everybody's got a little bit of a different twist on it. It's not like it's not the same thing for everybody, not even close. Very diverse.
Yeah, no, you're 100% right, and I think that's why a friend of mine, she said it's the experience. You have to talk about the AFib experience because it's individual in nature. Because there's technically not a shared journey for all AFib patients, right? Because it's just every which way. And it was interesting for me because your triggers were cold drinks. My trigger once I started getting up and running, and I was never a heavy drinker to begin with, but man, if I smelled vodka, even though vodka doesn't really have a smell, but if I even got a little taste out on my lips, I would immediately go into it. Now, a glass of beer would not do it, but vodka would. So I'm like, all right, that's weird. I don't understand that. So then I completely eliminated all alcohol together. After my multiple ablations, I periodically have a drink or two, but that it doesn't affect me anymore. Thank God. But so that's an interesting thought there. Now, Justin, I want to kind of go back a little bit because you had mentioned, obviously you were sleeping with one eye open and everything else. Can we talk, because we love to dive into the whole person side of care and also the caregiving side of it, from the psychological perspective, that one eye open all the time, talk to us a little bit about that. What did that fear or worry look like for you on a daily basis, and how did you cope with that for yourself?
I internalized that, to be honest with you, because I know that I didn't want him to know that I was worrying about him or that I was watching him. I mean, I was watching him. He didn't even know I was watching him, and I was watching him.
Yeah.
So, I kind of would just talk to myself, and I would try to talk myself down, like, Jessica, you're a nurse. If anything happens, I need plan A, B, C, so if something happens, I'm going to do this and this is going to happen. And, I always had a plan in place, I guess you could say. And it was a lot in the beginning. I felt very stressed out. I was anxious, You know, I had a lot of anxiety around it. I really couldn't sleep that well because he would go in it and go to sleep. And then he would, tell me he can't sleep on his left side. And so I would always kind of wake up and see what side he was sleeping on, or, if he was breathing, just the kind of the checks that a nurse would do on an ICU patient. Like, so it felt like a lot at first, because there's that emotional aspect too, as his wife, and I love him and I want to make sure that everything's going to be okay. And so in the beginning, it was a lot for me. I was a little afraid, to be honest with you. I was. I mean, when I'm in a hospital setting and you have all of the tools that you need, you're confident, you know what to do, you have a team to back you up if you need it. I'm by myself at home with nothing, and so, I know Scott likes, like I said, we talked about, he likes to minimize things, and I know he doesn't like me to worry, but this is our reality right now, and I want to make sure that, I can be here for you the best that I can be.
Sure.
So
I kind of had the easy job because I just slept through all that.
he didn't even know.
That's funny. That's funny. Yeah, right. I mean, no, that is pretty much it too. And from that perspective, but at some point you said I need to get some help, right? And you said that for yourself. And who did you rely on for that, or how did you kind of overcome that anxiety and everything else to get you in a place where you were coming at it? You were still, obviously the concern was there, but maybe it wasn't as overwhelming for you.
Well, I think I just, learning about it, finding out the facts about it, you know, having transparent conversations with Scott about our plans and how if anything happens, he's going to let me know. We're not going to pretend like nothing is wrong if something is going on. So I think it was a lot of that really helped ease my mind. And then just, of course, over time, he got his ablation. Things were going well. He was starting to get back into his training. He was using a monitor while he was training. So he had things very much in control and was aware now of his body, and what he could and couldn't tolerate. So, I think just having those conversations and learning more and having that knowledge really helped me.
Yeah.
And then, of course, we have the support of our wonderful family who are always there for us.
Right.
So,
right. No, that's great. And so, Scott, I want to ask a question. So it was over a year ago that you had the procedure done. What kind of an ablation did you have? Did you get the PFA, the pulse field ablation?
Yeah, it was pulse field.
Okay.
Yeah, I wanted to be sure that I got that. It's obviously a shorter procedure, less complications potentially, and it seemed like that was definitely the way to go. And
yeah, that's good. Yeah, that's good. And the two ablations I had were radio frequency, so PFA was not out at the time that I was, and I think because my procedures were both 8 hours in length, so you can imagine, after the first one with my wife, and it was 9 hours, and she told me post the event, she was like, "How bad were you? Like, my gosh, why were you in there for 9 hours?" Right? Not knowing that obviously RFA takes a little bit longer to go through the whole process, et cetera. And so that's the beauty of one of the beautiful aspects of PFA now is that these procedures can be done a little faster, and get patients out and away from it as soon as possible, which is great. So here's a question for kind of both of you as again, drawing that fine line in between clinical and spouse self at home. How did you find that ability to kind of separate the two, and how did that work out for you? Or maybe you just answered that and I'm just ignoring that, but maybe there's a little something more there.
I don't know if that clinical side ever really leaves, if that makes sense. There's always like a part of me that's looking out a little bit, but I don't know. What do you think, Scott?
Oh, I think that by nature you're a vigilant person and
sometimes hypervigilant,
a bit of a guardian. I mean, maybe that may have been instilled in you from having little brothers that were like
maybe
a few years younger than you that you were responsible for sometimes.
Right.
So I think your childhood, your upbringing shapes you to do those sorts of things as well. So, I mean, I think that, I don't know, it just seemed kind of seamless what you
Okay.
did do
Mm-hmm.
with, what you do at work, and then you come home and, I,
All right,
I,
right back into
I
nurse
try,
mode.
I
Right.
wasn't always the best patient, so.
He wasn't always the best patient, but we worked through that. We worked through that
Yeah.
part.
Well, isn't that always it's always funny, right? It's kind of like you see the healthcare workers smoking a cigarette as they get off the job,
Right.
right? So it's like you often wonder like, what are we doing here, right? So
Yeah.
no, that's well, I appreciate you sharing that there. So if we look at your kind of journey together, and we talk a little bit about here a lot is the center of excellence, right? And that's how each individual person can kind of become their own center of excellence because yes, you want to have a full person care team, but from an individual perspective, if people want to do this, Scott, I want to ask you first from the patient perspective, what would be one little bit of advice that or what you do on a daily basis to continue to make yourself that center of excellence that you are now and what you were becoming, post diagnosis.
Well, I think that we all have a responsibility to ourselves to keep ourselves in the best health possible. And I think the things that I do maybe better than I did before is I'm a little more vigilant and a little more willing to report any kind of a problem, talk to my physician, which I didn't even have until this
Right,
all
right.
started, which is kind of absurd if you think about it. But also, daily things like, taking care of myself, making sure that I'm ingesting things that are healthy. And Jess and I are 100% on the same page with this because
That's great.
she's very mindful of what she eats and what we have to eat in the house. I mean, it's just
Yeah,
it's easy.
yeah,
And the other thing is exercise and fitness and things like that. I really changed from a more masochistic approach to it to being kinder to myself.
yeah. I love
Still
that.
obviously challenging myself from a fitness level, but every effort doesn't have to be maximal. Every time you train
Right.
shouldn't be where you're pushing into these heart rate zones that are probably not good for you. It's okay to do those kind of things once in a while, but you got to be judicious about it, I think. And I believe it
Right.
was you that told me, kind of set a heart rate limit, and that's what I've done,
Yeah.
and really stayed under that. And it's made my training more enjoyable,
Yeah.
less brutal. And I mean, I don't feel like I've suffered any decrement in fitness from doing that. Actually, it's probably better
I think
because
so.
I'm
Yeah.
able to train not as stressed and not as injured.
Yeah.
Right, and I remind him, we're training for longevity at this point,
Exactly.
Right.
Exactly.
so let's be smart
Yeah.
about it. Let's challenge ourselves, but let's,
Yeah.
that's what the goal is.
There's a
Yeah.
point in your life as an adult where training like you're 25 goes from okay to idiotic. And I mean, I don't know where that point exactly is, but it's
Yeah.
somewhere.
Yeah.
You know.
Yeah, it's funny. I'll share this story with you, and I appreciate you sharing that. And I do remember you and I having that conversation, Scott. And I don't know where I said it for myself, but I said I don't want to get any higher than 140 beats per minute if I'm doing any type of aerobic exercise, and that's kind of the threshold that I've kept, and I try to keep it there. But it's funny now. I have two young boys, 16 and 18, and of course they work out like crazy. And they said, Dad, let's take a look at your workout program here. And he's like, I don't understand. He's like, what does this mean? Like, why are you walking every day? Like, when are you going to go a little bit more intense? And my younger son is like, he can't go any more intense. Like walking is good enough. It's fine. Like, and I do. I walk 3 miles a day, right? And I lift heavy weights. That's all I do.
That's
And
great.
I think I'm in the best shape of my life outside of college, but I'm within 5 pounds of my college weight, so I'm doing pretty good with that. But and I know obviously we might be considered maybe in some people's views maybe not extreme, but hardcore working out 5, 6, 7 days a
Mhm.
week. But I want to emphasize it doesn't have to be that way, right? I
Right.
mean, it could be 3 days a week or just
Yes.
walking or even gardening. Just movement as medicine is so
Yes.
important just to keep the joints moving. And it doesn't have to be much is what we want to say. All you have to do is just get started. For anybody that's looking to start to become their own center of excellence, just go out for a walk, 10, 30 minutes, 10 times or three times a day for 10 minutes or 30 minutes as a whole, whatever. It doesn't matter. It's just get moving. So I really appreciate you sharing that side of it there, because I think it's just, it's basic, right? And so Jess, let's shift a little bit now to the caregiver side on that same center of excellence side of things, giving what you shared about the anxiety and everything else that you went through. Now that you're on the other side of that a little bit, what would you say is the pearl that you could share for folks that are trying to build the caregiver center of excellence as well?
Well, I mean, going off of what Scott said, I think exercise is an excellent outlet. But I also advocate for therapy, having another outlet, maybe somebody like a therapist who you can just talk to about your experiences and kind of let out your worries and the things that you're going through on a daily basis. Because I think sometimes when you're able to vent, so to speak, it helps with that. You feel
Yeah.
better, also, maybe there's somebody who can come and give you a break. Go get your nails done or your hair done, or something like that. Go do something for yourself, because that is important too, to just kind of step away and collect yourself and then go back refreshed, and but
Yeah.
and also like we talked about, exercising is huge, because obviously that's a big part of my life too. So
Yep.
mhm.
No, it is so important, and the work that we do with my partners at Nudge Health, right, for people outside of just dealing with any cardiometabolic side of things, there's always a high level of anxiety, depression going on with that. But what's interesting is, and what we know is, the minute they start getting movement going, their anxiety and their depression scores start going down, right? And then what happens
Oh
on the
yeah.
reverse? So if their anxiety and depression scores go down, guess what else happens? Then their activity level actually increases, because now their confidence and things are starting to pick up. And I often,
Yes.
share this because we've all probably taken a flight before too, right? It's like, if we're about to lose oxygen, right, put your oxygen mask on first before helping somebody else. And I think we need to remind ourselves as a caregiver, like, that's the way it should be done, right? Because you can't help somebody if you yourself can't breathe. So
Mhm.
that's where we want to leave it at. That's great. Thank you for sharing that side of things. And as we start to shift a little bit now towards the closing of our conversation, you know, if there's something that you guys could say to healthcare worker that was just diagnosed, and also a caregiver, like, what would be the one thing that you'd want to say to them, if it's, again, another healthcare worker and a caregiver being the same thing? What would it be?
I think my biggest thing is allow yourself to receive care and help. I think as a nurse or physician, you're kind of maybe a little resistant to were you a little resistant? Do you feel like just allow yourself to get that help and that care that you need? Um, I think that's really important.
Yeah.
Yeah, I agree with that 100%. I don't particularly seem to have a problem myself with just transitioning from being a patient or a physician to a patient. I mean, I know that a lot of people tend, especially people in healthcare and in demanding careers, just in general, tend to be a little bit more want to be in control.
Well,
Yeah.
not. I'm sorry to interrupt, but
Go ahead.
he's the one that everybody comes to for help, for advice, especially in our family, and now the tables are turned. So,
Yeah,
you know,
and I don't have, I had less of a problem than I probably would have expected. Just being a patient and
Yeah.
going with the flow. I mean, once
yeah.
I'm, on the other side, I'm just going along with it, and I'd rather nobody even know that I'm in medicine.
Right.
And,
Right.
but like, I still think my biggest mistake was just not letting Jess be as involved as she wanted to be. I still was trying to exert a little bit more control than I should have on
Sure.
that end. And
Sure.
that's where I still giving myself an F for that.
And maybe that's why I said allow yourself to be
Yeah.
treated, allow yourself to be cared for,
Yeah.
especially by the people who love you. That's what we're here for in
Yeah.
those times.
Right.
It's
Right.
not a burden in any way. We're going to do this together, you
Yeah.
know?
Uh,
So,
I love that. I love that. And that's why I was so excited to have invited you guys come on to the show, because I knew you were, you were a picture of all of that people should be doing, and reaching out and supporting each other. And I also want to emphasize too, right? There are a lot of people out there that don't have anybody, but you don't have to be alone. There's large
Mhm.
communities of AFib patients, AFib caregivers, you name it, or just neighbors. People want to
Yeah.
help, right? Don't suffer alone, because we know that's really even more detrimental to your health. So reach out, join a
Yeah.
community. That's why we're doing on AFibulous Life, is to say, hey, you're not alone. You don't have to do this alone. So Jess and Scott, thank you very much for really letting us into your house tonight, and for sharing with us this personal experience that you've had. And I think what you've shown today is that AFib doesn't just happen to one person in a household, it certainly happens to the whole relationship in the household. So until next time, let's continue to live fully, lead boldly, and never stop writing your own story, because your heart definitely has more to say. So keep listening. This is the AFibulous Life. Scott and Jess, thank you so much for joining us this evening, and we'll see you guys in 2 more weeks. Until then, take care, and we'll talk to you soon.
Great. Thank
Thank
you for
you.
having us.
Thanks.
My pleasure.